Hello, I'm Eitan Raz. I'm a neuroradiologist and neurointerventional radiologist at NYU Langone Health in New York. I will talk today about a few things related to spinal cord. In particular, I will show the vascular anatomy of the spinal cord, speaking about the anterior and posterior spinal artery anatomy. And then I will demonstrate what is the appearance of spinal infarct on imaging, again with reference to anatomy, showing some spinal cord stroke examples. And I will also speak about vascular malformation of the spinal cord, more so in reference to the dural arteriovenous fistula. Now, starting with the anatomy, this is a graph that will show how the vessels in the spinal cord form. So this represents is a simplified appearance of the spinal cord, and the vascular of the spinal axis is systematically determined during the first few weeks of development as a consequence of the somatotopic organization of the spine. So during this embryologic interval, 31 somites are formed, and each somite will give a separate vessel that will supply a segment of the spinal cord. And these on this example I just draw a few of those. Each vessel we will call a segmental artery, and this paired segmental artery coming from each side, from what is called the dorsal aorta, support a functionally distinct vascular compartment comprising each developing metamer. So once the vessels form, the paired segmental artery form, the next step that happens is actually that at each segment ascending and descending vessel form from each side. After this, what happens is that these ascending and descending segment fuse, forming what we call paired ventral neural longitudinal arteries that runs along the anterior spinal axis. The next step after this is actually a fusion at midline with regression of some metameric arteries. And this is the appearance in which some of the metameric arteries are now regressing and some of them instead become more dominant. And this is representative of what the future spinal cord appearance will be, with some segmental arteries supplying the anterior spinal artery. The dominant segmental vessels will be called radiculomedullary arteries, and we will show a few examples in the next slides. This slide shows a very important concept, which is that the segments are fused, are connected. There are anastomosis that connects each segment, like from top to bottom. And in this scheme, you'll see, like here we have the cervical vertebrae, here we have the thoracic vertebrae, and then the lumbar and sacral vertebrae. And you see on this great graph by my colleague and friend Max Shapiro that draw for his website www.neuroangio.org. And you see how the anterior spinal axis is this one, but the segmental branches are connected through this anastomosis that runs along the side and along the posterior aspect of the vertebra. These vessels that connected separate metamers have different names across the body. Like in the neck, these vessels are called vertebral artery, and we know that very well. But there are also ascending cervical artery, more anteriorly connecting the anterior part of the segmental vessels, and then longitudinal anastomosis posteriorly. In the neck, we have what we call the deep cervical artery. Within the thoracic and lumbosacral region, like this vessel, have different names, but the concept is the same. So we have these longitudinal channels that connects different segments. What the appearance on the anterior surface of the spinal cord will be this one. So we have multiple segmental arteries, out of which some will give a radiculomedullary supply to the anterior spinal artery. the radiculomedullary supply to the anterior spinal artery will have a few dominant vessels, like the one that we all know, we heard about it, is the Adamkiewicz artery, which is the dominant radiculomedullary supply to the thoracolumbar segment of the spinal cord. But we will have other radiculomedullary supply to the rest of the cord. The disparity in the growth between the body and the spinal cord will account for the obliquity of these vessels, that originally they're straight, as I showed in the graph before, showing the embryological formation, but with the disparity in the length, that in the growth, that will determine this oblique appearance of both the arteries and, as we will see, the veins. This is the appearance of an aortogram. So here we have a pigtail catheter injecting the dye within the descending aorta. We see all these are all the segmental arteries, okay, and on the right side, on the left side, and some of which will give the radiculomedullary supply to the spinal cord. These instead are specimens from Armin Thron, which who historically has been like the expert for the spinal cord vascular anatomy. There is an excellent book that he authored about this, and on this specimen we see like exactly this concept. Here we see like a radiculomedullary artery supplying the anterior spinal artery. Here we see another radiculomedullary artery supplying the lower thoracolumbar thoracic cord. And in this other patient, we see a dominant radiculomedullary artery supplying the spinal cord. The anterior spinal artery, as we said, though, then receives multiple contribution at various levels from successive radiculomedullary arteries that arise from the various segments. The origin and number of radiculomedullary arteries range from 6 to 10 in the adult. These are images from an angiogram. In this case, the left T11 branch is injected. Here we have the same image with a unsubtracted view with the vertebrae on the background and a subtracted view without the bone. The unsubtracted view is good to show how the anterior spinal artery, which is this one, is really midline, and we see how it's really like midline along the spinous processes. So what happens here is that by injecting the left T11 segmental branch, we fill the right T12 segmental branch, which is here, through anastomosis. And the anastomosis, as we said, they're up to down, but they're also left to right. And once the right T12 branch is filling, then we see the contribution to the Adamkiewicz artery, which is this one, dominant radiculomedullary artery, supplying the anterior spinal artery. Here, another example with a nice graph that shows like the anterior spinal artery all the way from the upper brainstem all the way to the conus medullaris with different contributions from different levels. Here we see like the injection, in this case is a left T9. Again, the Adamkiewicz can be very variable. It can arise from different levels in different people. Usually it is in the lower thoracic upper lumbar region and more commonly from the left side. The left T9 is injected. It supplies the radiculomedullary artery, the Adamkiewicz artery, with then opacification of the anterior spinal artery all the way down. These two images are just images obtained at later in the phase. This is an early arterial phase. This is more like a capillary phase of the same injection. And you see how in the capillary phase there is like some blush along the expected location of the spinal cord. You can also appreciate now the blush of the vertebral body, because the segmental artery that we inject is also the same segmental artery that provides flow to the bone. This image shows well the concept that the radiculomedullary artery supplies the anterior spinal artery, but there are potential anastomosis with other radiculomedullary arteries. And here, if we inject hard enough in this vessel, we can overcome the pressure from this particular other segmental branch and this particular radiculomedullary artery, so we can opacify it. But this, again, is another radiculomedullary contributor to the anterior spinal artery. These are images from a vertebral injection, and we show how this is a very well visible anterior radiculomedullary supply to this particular part of the spinal cord. And you see how the obliquity here is a little different because of the different growth is actually like in the lower part of the body. So here the obliquity is much less obvious than in the thoracolumbar region. The classical herp and turn is classical for the Adamkiewicz artery rather than for the upper contributor to the anterior spinal artery. This particular image, which are stereoscopic, meaning that if you're able to cross your eyes, like you can see this image essentially in a 3D perspective, it shows the contribution to the anterior spinal artery from the interdural vertebral artery. These are lateral view of the vertebral injection. Okay, and then you see the contribution to the anterior spinal artery from below, and the two vessels form like an arcade. Here we also see a contribution to the posterior spinal artery that we will touch upon briefly. This is a graph showing how like the radiculomedullary artery enters by going like essentially running very close to the nerve root sleeve. And in the same space, we will also have some veins that we will exit the spinal cord through the same region. Usually in drawing, like these vessels are represented very straight. They tend to be straight, but not like in this drawing. In a real world, you will see the vessels a little more curved and irregular than what is described in most of the graphs that you find online. When talking about the posterior appearance of the spinal cord, we will have the posterior spinal arteries that instead are organized around two longitudinal channels that are located in the posterolateral aspect of the cord. The contributor will be similar. We will have herping vessels arising from some segmental branches, and this herping vessel will have a more acute appearance than the one that contributes to the anterior spinal artery. The posterior spinal arteries are then organized around these longitudinal channels that are here, as I said. And usually in the adult, we have around 10 to 20 radiculopial branches. So the supplier of the posterior spinal artery are called radiculopial branches compared to the, as I said before, the radiculomedullary arteries that supply the anterior spinal artery. This graph shows the supply from some segmental branches to the posterior spinal artery through the radiculopial branches, and the supply to the anterior spinal axis through some other radiculomedullary artery, in this case the Adamkiewicz artery. The anterior and posterior spinal artery can connect, and we will show in a different slide later. They're connected like on a horizontal perspective, but also at the conus medullaris we'll have what is called a basket, in which the anterior spinal artery connect really like a basket with the posterior spinal arteries. This is the appearance, typical appearance of a posterior spinal artery. Now this is a left L3 segmental injection. This is a subtracted and an unsubtracted image. Again, good to see the relationship between the arteries and the bone. And we see how these are the spinous process. And we showed before how the anterior spinal artery is really like in the midline. Here, when we see this hairpin-like vessel, we see that it is a little lateral compared to the spinous process. This is a typical appearance of a posterior spinal artery. Now, the important thing about those vessels is that, again, like they can connect. These are the posterior spinal artery, this is the anterior spinal artery, and these vessels are connected through superficial branches that we will call circumferential PL branches. So the anterior spinal artery and the posterior spinal artery connect through these circumferential branches. The anterior spinal artery, which runs within the anterior median fissure, will supply the anterior 2/3 of the spinal cord through these perforating branches that we will call sulcocommissural branches. Putting together the anterior spinal artery supply from different vessels, we will identify different zones of the spinal cord that will be supplied by different vessels. And this is an excellent graph by Dr. Gayoud from Johns Hopkins, in which he just explained this concept very directly. And here, this is like a representation of the spinal cord, and you see in different color is the different part of the spinal cord supplied by a different artery. And these different radiculomedullary artery will have different names. We call usually the one that supplies the thoracolumbar region, we will call it the artery of Adamkiewicz. Then there will be one that will supply this more superior spinal cord at the thoracic level, which sometimes is called by this name, artery of von Haller. And then we will have one or two other dominant radiculomedullary arteries, usually arising from the vertebral artery, supplying the upper part of the vertebral of the spinal artery. So this understanding will help to understand the concept of the spinal cord vascular watersheds. And the watersheds of the spinal cord vascular territory will be along the longitudinal axis of the upper thoracic spinal cord between the arteries of the cervical and lumbar enlargements. And here we see that very well, in which we see how in between these different vessels, these will be locations of watershed. The watershed will also be, though, along the gray-white junction between intramedullary territories of the rami perforantes and the sulcocommissural branches. So, since we understood before the anatomy on a cross-sectional level, we will understand that these areas will be more or less the watershed territories on a horizontal appearance. And this also will make us understand better the concept of watershed. We see here, this is an injection of a vertebral artery, this is a lateral view, and we see how the vertebral artery is opacified. And here, this vertebral artery supplies the spinal cord through two different radiculomedullary vessels. And these two vessels that supply will supply different part of the anterior spinal artery, and this particular here will be a watershed territory in between the supply from above and the supply from below. So, moving towards spinal cord infarct, the most important thing is to recognize and suspect it clinically. The most important part is that it will present with an abrupt presentation of symptoms related to depending on the level where the infarct is. Sometimes also we have to remember that a spinal cord infarct can present also with back pain. Typical appearance on imaging will be that of a slight hyperintensity on T2, usually like of the anterior aspect of the cord, sometimes with this owl's eye appearance. In a patient, if in this patient diffusion is done, we will show that there is a slight hyperintensity on diffusion at that particular level with reduction of the ADC. It's important to look at the aorta in these patients because there could be usually that's most common etiology, and we can find some abnormality of the aorta. This is another example in which we see there's abnormal intensity of the lower spinal cord. We see this in the axial T2 view. Interestingly, we also see that there is abnormal appearance of the bone. This is there is a bone infarct which is related to the occlusion of the segmental artery. So the segmental artery gets occluded. We know it gives supply to the bone, but also through a radiculomedullary artery, in this case to the spinal cord. So that's why the association of the findings. How do the findings evolve in days? Like this is like an acute appearance, and it can be a very subtle diffusion restriction, almost tough to see. Then a few days later, it can become much, much more obvious. And this is a great example that shows exactly this concept. So acutely, like we can expect something very subtle like this. And in terms of how the findings evolve, also we have to remember that we will expect to see some enhancement if we repeat the image in a few days. So what's the etiology? Most of the time is actually like a problem of the aorta, like atherosclerotic disease. And this is a great graph because it shows, like in one image, it shows multiple different possible etiologies. And again, like the aorta can be a problem. There can be a disc issue that can compress the laterally, a segmental branch. It can compress like more posteriorly the vessel. Like in this level, it can be a lateral disc herniation. Another potential factor is actually compression from the crust of the diaphragm, shown here. And that can compress the artery that gives the radiculomedullary artery. Look at this example in which we see how there is abnormal signal within the thoracolumbar spine, and you see on the axial view how this is a typical appearance of the Ohl's eye. In this other example, again, abnormal signal in the lower spinal cord, Ohl's eye appearance. What is interesting about this is that on the same image, you can also recognize that there is a dissection, which is likely a dissection of the aorta, which is likely the cause of this infarct. Don't forget that an infarct of the spinal cord can sometimes be caused by spine surgery. So if it's at the same level after surgery, think of that as a possible etiology. I also wanted to show you another iatrogenic case. This is a patient that came with a massive hemoptysis. They did a bronchoscopy, and for that reason, because he was bleeding from the bronchi, he underwent the bronchial angiogram. First, an aortogram was done, and which didn't show anything at that time. And then the catheterization was done. Particles were injected to block the hemoptysis, and then the patient woke up paraparetic. They did an MRI, which showed here, if you see the anterior spinal cord here is abnormal. And what happened is that we reviewed the imaging of the patient when he arrived. And if you look at in better detail those images, it's obvious that there is a radiculomedullary artery arising from this particular vessel, which is connected in some ways here with the bronchial artery that was embolized. This was from the aortogram. This is from the bronchial artery that was embolized, and you see here that first, from some reason, through collaterals, this vessel is then filled. Same vessel. So this is a iatrogenic spinal cord infarct. This is another interesting case. Patient comes in with a right side sensory loss, and this is how subtle the findings can be. Look at this little abnormality here of the spinal cord. Okay, here on the posterior lateral aspect, very hard to see. T1 is done, and the T1 shows very well the finding, because look at the left side. There is a good flow void of the vertebral artery, normal vertebral artery. Right side, there is actually a dissection of the vertebral artery. And when you go back and look at the diffusion, now it becomes very obvious that there is a thrombus here in the right vertebral artery. There is a dissection. You can see how there is a little posterior lateral spinal cord infarct. So this is a vertebral artery dissection with a lateral spinal artery territory infarct. This is another unusual case in which you see like a posterior here, like almost like very irregular line of abnormal signal intensity in the posterior spinal cord. And again, like when you have something like that, it's very important to look at the vessel, look at the flow voids, and here it's obvious that this patient had a dissection of the left vertebral artery, and which probably was giving off a posterior radiculopial supply to the posterior spinal artery. This is a follow-up MRI in the same patient showing the resolution of the dissection. This is another very interesting case of an 18-year-old patient with decreased sensation and movement to the bilateral lower extremities after surfing. He reports lower back pain, and then he started feeling gradual loss of movement. This is the MRI, abnormal signal in the conus medullaris. On the axial view, you see here the typical abnormal signal intensity of the lower spinal cord, and diffusion is done, which shows very well how there is diffusion restriction of the same region. This is another example from the literature in which we see the same particular appearance, and the diagnosis in this case is surfer myelopathy, which is a kind of a anterior spinal cord infarct. It happens to inexperienced surfers, with pain and sign of spinal cord stroke. You will have the typical appearance of a spinal cord infarct. And why this happened is considered an ischemic injury of the thoracic spinal cord due to prolonged prone hyperextension. It's not sure that that is the cause, but that is postulated. Don't forget the occurrence of spinal infarct in vascular aortic surgery, and you will have approximately 1 every 130 between endovascular and surgical aortic treatment, and the etiology is usually thought to be to hypoperfusion. The risk of permanent ischemia after TEVR is less than that of open repair, and usually the extent and number of stent graft is a risk factors for this development. So that's why in case of long construct to be done, staging is recommended, so it can give time to collaterals to form. While instead, if all the radiculomedullary arteries are covered at the same time, that can become a problem. Moving to spinal vascular malformations, you will find multiple classifications in the literature that will divide dural arteriovenous fistulas from intramedullary arteriovenous malformation, juvenile arteriovenous malformation, or perimedullary arteriovenous malformation. Don't forget that there's also other vascular lesions in the spine, such as intramedullary cavernous malformation, and also, don't forget that there are spinal vascular tumor. The most important, by far, vascular malformation in the spine is the dural arteriovenous fistula, because it's more common, it can be readily diagnosed on cross-sectional imaging, and will have very typical features. In order to understand that, we have to understand the venous anatomy. So let me describe that for a little. When we think of the venous anatomy, we can describe different systems: the intrinsic system within the spinal cord and an extrinsic system, which is outside of the spinal cord. And those obviously will be connected with the extradural system that will bring the venous outflow toward the external system, such as eventually the vena cava. Now, when we look at the injection of the anterior spinal artery, such as in this case, there is a left T10 injection, and we have 3 sequential images of the same injection, in which we see the anterior spinal artery, supplied obviously by radiculomedullary dominant Adamkiewicz artery that arises from this level. But if we see later on, we will see how we go to a capillary phase, and then we'll go to a venous phase. So if we pay attention to the venous phase, we will see other hairpin turn sort of vessel, and these are the dominant radiculomedullary veins that again will not be at every single level but at some particular levels. But the radiculomedullary vein will be very similar in anatomical configuration compared to the radiculomedullary arteries. In order to understand more the extrinsic system, like one of the best ways is actually to look at some of the CTAs in which there's reflux in the vessels in the neck. In this case, for example, the reason for the reflux is that there was thrombosis or occlusion of the left subclavian vein, so the flow goes all the way up to the jugular vein and finds collateral ways through the other veins in the neck, and this will opacify all the extrinsic system. Again, it's not a vascular malformation, but it's a good way. It is a good example to understand well how the epidural channels are connected with the external system. These images are from a right internal iliac injection, and we see how there's opacification of the vein, epidural veins around the lower lumbar region, and we see how really the veins are connected, forming this sort of diamond shape in the epidural space. So let's go back to vascular malformation after this debrief of the veins, and let's talk about spinal dural arteriovenous malformation, which are abnormal communication between the radicular artery in the nerve root sleeve and the intradural venous system, causing venous hypertension. It's the most common spinal vascular lesion, explaining 70% of the spinal vascular malformation. It is more common in males, with a mean age of presentation of 60 years old. The symptoms are typically progressive, and they can be motor, can be sensory, depending on the particular part of the spinal cord that is involved. But the important thing is that the symptoms are progressive. And in order to understand it, catheter angiography is the gold standard. So, where do spinal dural arteriovenous fistula form? Usually they form here at the nerve root sleeve. So here we have at every level we have a little artery that supplies the nerve root. Okay, some of these vessels again will become dominant and supply the spinal cord, but some will just supply only the nerve root sleeve. At some levels we will also have veins. Okay, and this is the location where, for some reasons that we don't know well, this is the location where fistula forms between the artery and the vein. Once this fistula forms between an artery and the vein, what happens is that the vein is now under much higher pressure. So the vein becomes arterialized. So what happens? The flow and the pressure in the vein will start to be retrograde. Will start to go retrogradely toward the spinal cord. So what happens next? The spinal cord will start to be under, the spinal cord venous system will start to be under much higher intrinsic pressure. And this increased pressure and venous congestion of the spinal cord will determine the suffering of the spinal cord and the symptomatology that the patient will present with. This is typical appearance of a patient with a spinal cord dural arteriovenous fistula, and you see here how the patient was normal before, and now he comes back many years later, and for some reason he had this MRI done many years before. Now he comes back and we see that the spinal cord is abnormal and there are new flow void around the spinal cord, and the spinal cord is also enlarged. The reason is that the spinal cord is suffering from venous congestion, and the vessels that you see are enlarged around the spinal cord are increased size venous spinal intrinsic vessels. This is the appearance on angiogram, and what happens here when we identify the level of the fistula. This is like the catheter here injecting the dye. This is the segmental artery, and the fistula is here where the red arrow is. So here is where the artery becomes vein, and then the vein finds its way through the spinal cord. So what we see opacifying here is the are the veins surrounding the spinal cord. And because of this increased pressure in the vein, the spinal cord will suffer from venous congestion. Now, this vein, interestingly, can go all the way up. And we see in this particular patient, if we keep looking at the image, we see how the vein go all the way up. And this was in the lumbar region. And look at this, where it's going all the way up to the thoracic spine, all the way up actually through the cervical spine. And then finally it finds the outflow through a petrous vein toward the sigmoid sinus. So the reason is that probably there were no many radiculomedullary vein that this anterior spinal vein could have find to drain. So that's why there's drainage all the way up to the brain. This is another case in which we see, like, again, the typical like abnormal signal of the spinal cord with enlarged vessels surrounding it. Typical appearance of a dural arteriovenous fistula. The key is to identify the fistula, and in this case the fistula was at the foramen magnum with venous drainage through the anterior spinal vein that went all the way down. This is another example in which there is like this catheter is opacifying an upper thoracic vertebral body, and you see how like there is early filling of this spinal cord vein around the spinal cord that we can see very well also in the Dyna CT, like in this image. So these vessels, abnormal vessels, again, they are abnormal, increased pressurized spinal cord vein. How to treat a spinal cord dural arteriovenous fistula? The treatment has to be, usually it's endovascular treatment, but also surgery can be done for some cases. The important thing to know is that the natural history is poor, and that's why we treat them. The natural history is poor because if patients are untreated, they become severely disabled. The venous congestion tend to increase, and with that, the abnormal symptoms caused by that in the spine will become worse. To conclude the talk, I wanted to again point how the understanding of the spinal cord vascular embryology and anatomy is paramount for the understanding of spinal vascular conditions. Spinal cord infarct and the spinal vascular malformations can be recognized by cross-sectional imaging, but often spinal angiography is necessary for further evaluation and treatment. Thank you very much for your attention.